Welcome to Start MRCUG. Today I will discuss the Green-top Guideline, Care of Late Intrauterine Fetal Death and Stillbirth. Guideline started by two definitions about stillbirth, which is defined as a baby delivered with no signs of life and to have died after 24 plus 0 completed weeks of pregnancy. Second definition is about late intrauterine fetal death, which refers to babies with no signs of life in utero after 24 plus 0 completed weeks of pregnancy. The incidence of late IUFD occurs in approximately 1 in 250 babies. Risk factors for IUFD. They divided them into non-modifiable and modifiable. First, non-modifiable risk factors could be in the mother, like nullipara, maternal age above 35 or below 20, ethnicity like Black, Asian, and other non-white women, advanced maternal age, gestational weeks above 41 plus 0, and low educational attainment. Other set of non-modifiable risk factors: thyroid disease, thrombophilia malaria, COVID-19 infection, cholestasis, systemic lupus erythematosus, antiphospholipid syndrome, renal disease, something in the previous pregnancy, bad obstetric history like previous stillbirth, previous adverse pregnancy outcomes, preterm labor, preeclampsia, something in the current pregnancy like fetal growth restriction, multiple pregnancy, fetal growth restriction and or SGA, reduced fetal movements, the potentially modifiable risk factors, pre-existing hypertension, obesity, underweight, weight gain, smoking more than 10 cigarettes per day, alcohol use, illicit drug use, going to sleep supine position, living in areas of most deprivation. Diagnosis of intrauterine fetal death. Recommendations for the optimal method for diagnosis of late intrauterine fetal death. First, ultrasound is essential for accurate diagnosis, should be available all the time. Second, opinion should be obtained. Auscultation and CTG shouldn't be used to diagnose late IUFD, and the woman should be prepared for possibility of passive fetal movements. And if a woman reports fetal movement after the scan to diagnose late IUFD, repeat scan should be offered. Ultrasound is the optimal method for diagnosis because real-time ultrasound allows direct visualization of the fetal heart. Despite the imaging can be difficult in obese women like BMI over 30 kilograms per square meter or presence of scars or oligohydramnios, but we can augment the view by color Doppler of the fetal heart and umbilical cord. In addition, we can see secondary features which will appear in the ultrasound. We have collapse of the fetal skull with overlapping bones, hydrops or maceration, meaning to soften in liquid, resulting in unrecognizable fetal mass. Intrafetal gas within the heart, blood vessels, joints is another feature associated with late IUFD that might limit the quality of real-time imaging. Evidence of occult placental abruption might also be identifiable. However, sensitivity to diagnosis by ultrasound can be low as 15%. Even large abruption can be missed with ultrasound only. What is the best practice for communicating the diagnosis and subsequent care? Breaking bad news. If the woman is unaccompanied, an immediate offer should be made to call her partner, family, and friends. An appropriate place for the discussion should be found. Clear language with no euphemisms or jargon should be used. An interpreter is required. A professional one is preferable to the use of family or friends. Other formats of conveying information to those with learning difficulties should be considered. Woman and her family should be given time to absorb the news. The clinician should answer any questions they are capable of within their scope of practice. Discussion aimed to support maternal and paternal choice. And the woman and her family should be given written information to supplement the discussion, which should include information about ongoing care and contact details of named healthcare professional. And the staff should be sensitive to sounds that they may be upsetting for the pregnant parents and their family to hear. For example, the sounds which could be in the labor ward environment of other laboring women or crying babies. Continue with the care. We can learn the empathetic techniques, and they give us many websites which will help us in gaining the skill, like the National Bereavement Care Pathway e-learning program, National Bereavement Care Pathway, SAND is Stillbirth Neonatal Death Society training. So it is the SANS, and it is very important to provide written information as RCOG leaflet to the patient, and the name is when your baby dies before birth, or to consider alternative formats where this would help communication and understanding. Labor and birth. The mood of birth should be like an informed decision between parents and appropriately trained, experienced obstetrician. Vaginal birth is recommended for most women with the intent to optimize future pregnancy outcome. Cesarean section could be considered for some women. So detailed informed discussion should be undertaken with the woman and the partner regarding the physical and psychological aspects of vaginal birth versus cesarean section. We need to inform them about the pros and cons of cesarean versus vaginal delivery. Vaginal delivery is a quicker physical recovery and return to home and optimize the future pregnancy outcome. While cesarean section will reduce the rate of perineal trauma, urinary incontinence, and pelvic organ prolapse, which happen with vaginal delivery. The cons of vaginal delivery, including vaginal and perineal tears, and the need for forceps ventosus or an emergency cesarean section, which of course carries higher risk of complications like extended tears, bleeding, admission to special care. On the other hand, the cesarean section has surgical morbidity and association with increased risk for fertility and risks in future pregnancies. Women and her partner wish should be taken into account. So, if the woman opted for vaginal delivery and it was safe option for her, we have spontaneous vaginal birth, immediate induction, delayed induction to have vaginal birth. Otherwise she can go for cesarean section or expectant management. Method of induction could include misoprostol, with or without mifepristone, oxytocin infusion, and mechanical induction. We have 10% chances that the mother may go into the IC within 4 weeks from the date of fetal death, with increased chance thereafter. Evidence has shown that vaginal birth can occur within 24 hours of induction of labor for late IUFD in about 90% of cases. Water birth in late IUFD is not contraindicated, and we have to consider the woman's choices as well as medical condition and her previous intrapartum history. Coming to the timing of the birth, when you see the woman, you have to assess her for risk factors like fever, feeling unwell to rule out sepsis, check her blood pressure and protein in urine to rule out preeclamptic toxemia, see signs of placental abruption, signs and symptoms of placental abruption, like abdominal pain, which is persistent, rigidity guarding in the abdomen, vaginal bleeding, to rule out placental abruption. Ask her if she has leak or smelly discharge. After you rule out all these risks, you can give her expectant management. However, if she has any of this patient is considered unwell, and she should be offered the immediate delivery regarding the timing. But if nothing from these risks, so more flexible approach can be discussed if this is not the case. And if the woman chooses to have expectant management and no evidence of DIC, you can give her expectant management for a short period, 48 hours, and you can reassure her that it is not expected that she will have any physical harm. But the issue here, that she could suffer greater anxiety with prolonged delays, and longer than 48 hours, DIC risk will increase. So the issue of anxiety and DIC should be highlighted to the woman. And because of that, if she returned home, you have to give her 24-hour contact numbers and written information about the signs and symptoms or that prompt actions and return to the hospital. We call warning symptoms and the signs. And also she should put in her account that the diagnostic value of the post-mortem may be reduced. In addition, because this is psychologically affecting the woman, she should expect that the baby appearance will be changed after the delivery, after waiting several days before the delivery. How should labor be induced for a woman with an unscarred uterus? We use combination of mifepristone and misoprostol, like a first line for induction of labor. We prefer misoprostol to prostaglandin E2 because equal in the safety and lower cost. Vaginal misoprostol is as effective as oral therapy, but is associated with fewer adverse effects. We use single 200 milligram dose of mifepristone, then will be followed by, according to gestational age. So between 24 plus 0 to 24 plus 6 weeks gestation, we give 400 micrograms misoprostol every 3 hours. Between 25 plus 0 to 27 plus 6 weeks of gestation, we give 200 micrograms misoprostol every 4 hours, and from 28 plus 0 weeks of gestation, we give 25 to 50 micrograms of vaginal progesterone every 4 hours, or 50 to 100 microgram oral misoprostol every 2 hours. Why we use mifepristone? They found shorter time to birth, increased chance of a vaginal birth from 71.2% to 92.5%. Misoprostol is off-label in the UK, and we have available 200 microgram tablet, but it could be dissolved in water and administered in measured amounts, or divided with a table cutter, and we can ask the pharmacy to prepare the cut tablets to reduce variation in the dose. 25 microgram tablet is now available in the UK, but it is not licensed for induction in these circumstances. They designed very nice table and very big table, which summarize essential investigations for late intrauterine fetal death, detailing their purpose, evidence level, clinical timing. Each test plays a critical role in identifying underlying causes or complications, guiding timely interventions. I have here in this slide 3 sets of investigations, which should be done as soon as possible after the fetal death. The first set is maternal standard hematology biochemistry, including CRP and bile salts. Here they are specifically to diagnose conditions like preeclampsia and its complications, multi-organ failure, sepsis, and obstetric cholestasis. Platelet count is required for occult DIC, disseminated intravascular coagulopathy. If it is abnormally low, we have to discuss with the hematologist, and it could and suggest repeating according to the advice. And here we have level of evidence, the maternal coagulation time and the plasma fibrinogen, which are designed for diagnosis of disseminated intravascular coagulopathy. It is not to diagnose the cause. It can help in diagnosis of sepsis, abruption, preeclampsia, and all increase the risk of having DIC. Why we need to know or rule out DIC? It is important before regional anesthesia because of the possible bleeding. It is very important to follow up patients who choose expectant management more than 48 hours since IUFD until birth. Horse we have which can be used to test for fetal-maternal hemorrhage as a cause of late intrauterine fetal death. Also, it will help to decide the level of requirement for the NTD. I can calculate the dose. So it is recommended for all, not only for Rh negative women. So if the woman is Rh positive, the lab should know that the woman is Rh positive. It could be used after delivery as well, so we will do it as soon as possible after diagnosis of late IUFD, and then after delivery we will do second horse test to determine whether sufficient NTD has been given to the woman or no. Why we do it as soon as possible after the delivery, after the fetal death? Because the red blood cells of the baby will be cleared rapidly from the maternal circulation. Doing as soon as possible is considered like a safety point in these patients late IUFD. Now another set of investigations which should be done as soon as possible after diagnosis of fetal death, including maternal bacteriology. We will not do routine. We will do if indicated only if the mother is feverish, have flu-like symptoms, if liquor is abnormal like purulent appearance or offensive odor, if the woman has history of prolonged rupture of membrane, can be used also to direct the antibiotic therapy. And we can do blood cultures, midstream urine, and vaginal swabs and cervical swabs to diagnose some kind of infections, suspected infections like Listeria monocytogenes and chlamydia. Level of evidence here is 1+2. We have other maternal serology we do before discharge, viral screening and tropical infections. Use a stored serum from booking test, which can provide baseline serology. They added some notes like high drops is not necessarily feature of parvovirus related late IUFD. Treponemal serology usually will be known, and the others we can do if suggestive history only, like travel to endemic area, like the tropical infections. The aim is to detect undiagnosed maternal fetal infections. Here, evidence is +2. In order to recap, we have 4 sets of investigations we have to as soon as possible, and as soon as possible is a safety point here, which will include the maternal standard hematology and biochemistry, including CRP and bile salts, coagulation time and plasma fibrinogen, Clehor's test, and maternal bacteriology, including blood cultures, midstream urine, vaginal swabs, and cervical swabs. We have another set of investigations, including screening for diabetes, thyroid, and thrombophilia. Screening for diabetes by maternal random blood glucose should be done as soon as possible after the diagnosis, because GDM usually returns to the euglycemia within few hours after late IUFD has occurred. Presence of other symptoms like severe ketoacidosis and other symptoms should alert the clinician to the need for glucose testing. Maternal HbA1c for undiagnosed maternal pre-existing diabetes or GDM. We can exclude by that occult type 1, type 2 diabetes, and can be indicative of GDM if HbA1c is more than 41 and it is indicated before the discharge. Thyroid before discharge also, like TSH 3T4, 3T3 for undiagnosed maternal thyroid disease. Maternal thrombophilia, we screen 6 weeks after birth. It is not reliable during the pregnancy. We screen for antiphospholipid syndrome, especially if there is evidence of fetal growth restriction, placental disease, and we screen by antibodies against beta-2 glycoprotein, lupus anticoagulant, and anticardiolipin antibodies. And if it is positive, it should be repeated after 12 weeks. Screening for inherited thrombophilia is not routinely indicated. Level of evidence here is 1+2. Immunological conditions, which could be the reason for intrauterine fetal death, particularly if there is evidence of fetal hydrops. We need to test for anti-red antibody serology and for occult maternal autoimmune conditions like maternal anti-Ro anti-La antibody, and we do that as soon as possible after the diagnosis of the hydrops. Or we have also maternal alloimmune anti-platelet antibodies to screen for alloimmune thrombocytopenia. It is indicated only if there is evidence of fetal intracranial hemorrhage and should be done as soon as possible after the diagnosis of fetal intracranial hemorrhage. Another set of investigations, including parental blood for karyotyping to diagnose parental balanced translocation, parental blood for karyotyping to diagnose parental balanced translocation and parental mosaicism should be done as soon as possible after the diagnosis of fetal genetic anomaly or suspicion of genetic anomaly. Indicated if we found fetal unbalanced translocation should be recommended by the gene test. Fetal genetic testing fails and history suggestive of aneuploidy, fetal anomaly on post-mortem, previous unexplained intrauterine fetal death, recurrent miscarriage. Maternal toxicology for occult drug use should be done with consent. If she had history suggestive or her presentation suggestive of drug abuse, it could be tested in the urine, nail, and hair. Meconium toxicology may be widely available and should be done as soon as possible after diagnosis of fetal death. We have fetal placental microbiology, including fetal blood swabs and placental swabs. The aim to diagnose fetal infections. It is more informative than the maternal serology. We can take cord sample if possible in lithium heparin. Written consent advisable if cardiac blood. Cardiac blood can be taken by the histopathologist and can be used for bacterial culture or genetic testing, and should be obtained in clean technique and should be done as soon as possible after birth. Another set of investigations, including fetal and placental tissue for cytogenetics and post-mortem examination. First, fetal and placental tissue for cytogenetics and the possible single gene testing. We do that on fetal cord and on the placenta. The aim to rule out aneuploidy, single gene disorder. We have to send several samples. Culture bottle should be away from formalin, kept in the refrigerator, and if single gene syndrome is suspected, the material should be stored, and it is absolutely contraindicated if the parents didn't wish to do. So we have to take written consent before doing this test, and it should be done as soon as possible after birth and after parents' consent. The last, which is a very important test in diagnosis of the cause of intrauterine fetal death, is post-mortem examination. We have several forms of post-mortem, including external autopsy, microscopy, X-ray, placenta and cord examination, ultrasound scan, and MRI imaging. External examination should include the weight and length measurement of the baby. Usually, fetal growth restriction is a significant finding with intrauterine fetal death. Perinatal pathologist or neonatologist can examine for dysmorphic features if parents don't want to do autopsy. Absolutely contraindicated if the parent didn't wish to do so. Written consent is required here. Should be done as soon as after birth and after parents' consent. What is the best practice for induction of labor for a woman with history of lower segment cesarean section? A discussion of benefits and harms of induction of labor should be taken by experienced obstetrician. Women should be closely monitored. Oxytocin could be used, but after a discussion with consultant or obstetrician with equivalent. We can use misoprostol between 13 and 27 plus 6 weeks of gestation. Between 24 to 24 plus 6 weeks, we use 400 microgram. We can use buccal, sublingual, vaginal, oral every 3 hours. Between 25 plus 0 to 27 plus 6 weeks of gestation, we can make it half dose, 200 microgram every 4 hours. More than 27 plus 6 weeks of gestation, there is insufficient evidence, so local practice should be followed. More than 2 lower segment cesarean birth or atypical scar should be advised as the safety of induction of labor is unknown. One previous cesarean section, the risk of rupture. One previous cesarean section, there is 2 to 3 times increase in the risk of rupture uterus, 1.5 times increased risk of cesarean birth in induced or augmented labor compared to spontaneous VBAC. In presence of 2 or more previous cesarean birth, it is not recommended to do the VBAC. Also, in presence of previous uterine rupture and upper segment cesarean section. How can we identify uterine rupture when we induce labor in late IUFD despite no fetal heart rate, which is the most common early sign of scar dehiscence, but it doesn't apply here? We can pick up uterine rupture by maternal tachycardia, atypical pain, bleeding, high hidden on examination, shoulder pain, hematuria, and maternal collapse. After 28 weeks of gestation with previous cesarean section, cervical ripening with transvaginal Foley's catheter has been associated with uterine rupture rates comparable to spontaneous labor, so it could be helpful, especially in women with unfavorable cervical examination. Periperium, where the woman is cared for, should provide adequate safety according to her individual clinical circumstances and while meeting their needs to grieve and feel supported in doing so. The woman should be suffering from acute medical problems like sepsis, preeclampsia, and possibly will need critical care. They may wish to stay with their babies at the hospital. If so, they should be kept away from the maternity unit if available facilities. GP should be informed. Lactation should be agreed with the woman. Lactation suppression or milk coordination sensitively could be discussed with the woman. Counseling for the lactation. They give support to the staff to improve the information on lactation following prenatal bereavement, and they give them a helpful 25-point framework has been developed to support the healthcare professionals and organization. Women should be informed about the warning symptoms and the signs and the usual findings in the preperium, including the physical symptoms like bleeding and pain, which could be expected, and when to contact the healthcare professionals. The woman discharged home, she should be continued care by the GP and the midwife. Contraception should be discussed before discharge home with the woman to avoid unplanned pregnancy. If we talk about the suppression of lactation, 1/3 who choose non-pharmacological method would suffer from excess discomfort. Pharmacological methods is recommended as a dopamine agonist, and usually it is successful in suppression of the breast milk and generally well tolerated. And we have bromocriptine and cabergoline. Cabergoline is superior to bromocriptine in suppression of lactation. Single dose of cabergoline 1 mg with bromocriptine 2.5 mg twice daily for 14 days days. The dose of cabergoline is 1 milligram. Bromocriptine is 2.5 milligram twice daily for 14 days. Careful consideration and balance of risk and benefit should be undertaken because they are contraindicated in presence of increased blood pressure in hypertension and preeclampsia, because they can increase the blood pressure and associated with intracranial hemorrhage. So when the woman is commencing the bromocriptine, blood pressure should be monitored during the first few days of treatment. Coming to the VTE risk assessment and prophylaxis, they consider the intrauterine fetal death like a risk factor for having VTE, and each woman should be assessed for venous thromboembolism and thromboprophylaxis after intrauterine fetal death. And the heparin should be discussed with the hematologist in case the woman developed DIC with intrauterine fetal death. Who should be informed in case of intrauterine fetal death? All key staff should be informed. Cancellation of all antenatal appointments should be done, and the aim of involvement of the key staff in order to ensure continuity of the follow-up, and they should include community midwife, health visitor, antenatal class coordinator, general practitioner, and all appointments for the antenatal class in the hospital or in the community, like ultrasound scans, pre-op assessment, maternity units, all should be informed, and the appointment should be cancelled. Other healthcare professionals such as the psychiatrist, secondary care specialist, and drug worker should be also contacted. And voluntary groups who distribute free items to new parents should also be contacted, while maintaining the confidentiality of the patient. Investigations of the cause of late intrauterine fetal death. What are the general principles of investigations? Detailed history and clinical and lab tests and full investigation, including post-mortem placental histology. Probable reason for death of the baby could be detected in around 3/4 of late IUFDs. Parents should be kept up to date with the process, and when a reason is found, it can potentially influence the current future pregnancy. What are the tests should be recommended to identify the cause of late intrauterine fetal death? Women should be offered post-mortem genetic and placental pathology. They found the most useful tests is arranged as placental pathology, fetal post-mortem, followed by genetic testing and testing for antiphospholipid antibodies. They found weak association between heritable thrombophilia and late intrauterine fetal death, and it is not recommended to do like a routine. Acquired thrombophilia antiphospholipid syndrome is strongly linked. They found that late IUFD and miscarriage were shown to be more common with antiphospholipid syndrome who had previous thrombosis compared to women who had not a poor outcome and only have positive antibodies, and the association with is more when she has positive antibodies, triple positive antibodies. Transplacental infections, including cytomegalovirus and the other set of infections mentioned here, like listeria, Coxsackie, malaria, sending infections, with or without rupture membrane, like E. coli, Klebsiella, all are implicated in IUFD in developing countries. What are the special actions should be recommended for women with Rh negative? If the woman is Rh negative, she should be offered Clehor's test urgently. Detect large fetal-maternal hemorrhage that might have preceded the late IUFD. And anti-D should be administered as soon as possible after the presentation. And the dose of anti-D should be adjusted according to the amount of the fetal-maternal hemorrhage detected, and the Clehor's test should be repeated at 48 hours. The idea of the Clehor's test is to detect the fetal blood cell which enter the maternal circulation. Usually, anti-D will be given within 72 hours of fetal-maternal hemorrhage and has beneficial effect up to 10 days. But the problem in intrauterine fetal death that the sensitizing bleeding will happen days before the diagnosis of intrauterine fetal death, and this will compromise the window of optimal administration of anti-D, which is 72 hours. That's why they recommend to test as soon as possible and to give the anti-D as soon as possible. Sometimes the fetal blood cell will be negative, but with large amount of fetal-maternal hemorrhage, it will give positive Clehor's test as well. So it is important to distinguish between two types of the fetal blood, whether Rh negative or positive, and they do that using the conventional serology in the cord blood. And they can do that also by the free fetal DNA from the maternal blood. And it is accurate in prediction of the Rh type of the baby. And it is routinely performed for Rh negative women in many units in the UK in the first trimester. What precautions should be taken when determining the fetal sex? Parents should be advised that there could be some difficulty in sexing the baby, particularly if the baby is macerated, and errors in fetal sexing could be harmful emotionally for the parents. That's why it should be very accurate, and we have to take opinion of two experienced healthcare practitioners like the midwife, obstetrician, neonatologist, pathologist should examine the external genitalia of the babies born extremely preterm or severely macerated or with hydrops. If there is still difficulty, we can depend on the rapid genetic testing like the FISH and the QF-PCR, which is highly accurate and can give the fetal sex result within 2 working days. And if this fails, we can depend on the post-mortem, but it will take longer time to determine the sex. And if still not clear, we can ask the parents to judge the sex themselves or depend on the midwife or doctor to make a judgment. Some parents could may choose not to sex the baby before choosing the name, and the stillborn babies can be registered as having indeterminate sex. What is the best practice guidance for cytogenetic analysis of the baby? Cytogenetic analysis should be offered to all women, and we have to take consent from the parent, verbal and in writing. It needs multiple cytogenetic techniques and samples from multiple fetal tissue to be more informative, and it is very important because 6 to 13% of stillborn babies will have cytogenetic abnormality, and if it is positive, referral to clinical genetist will be indicated.